But trust me on it, there was a 7 percentage point difference. So women in pregnancy who were using just finger stick glucose monitoring began their pregnancy spending 50% time in range, so about 12 hours per day. By the time they got to the end of pregnancy using finger stick, they got to about 60%. Whereas women who were using the real-time CGM got to 68%, so very close to that 70% target in the pregnancy-specific target range, so that's the 3.5 to 7.8. And if you don't work in pregnancy, never underestimate how much more difficult. So 70% time in the pregnancy-specific range is equivalent to about 90% time in the 3.9 to 10, the range for outside of pregnancy. So never underestimate just what an achievement it is to get even 50%, even 60%. But of course we know for the best obstetric neonatal outcomes, we want as many pregnant women as possible to get to 70% time in range. But Partha often says that, and I totally agree with them, your research is worth zilch if it doesn't get into the lives of people with diabetes. So actually it has been a great pleasure to work with the Diabetes Technology Network, Diabetes UK, JDRF, NHS England, the diabetes programme at NHS England and the maternity programmes together to really make sure that the advantages and the benefits, the clinical benefits we saw in the trial were able to be translated into real world benefits for pregnant women with diabetes. And that's what we were able to release yesterday in the State of the Nation report. So some of you will remember the NICE guidelines were updated in December 2020. And all throughout 2021 and 2022, we collected information on which women were using finger stick glucose monitoring, which were using intermittently scanned or flash monitoring, and which were using real-time CGM. And this is probably the single most important and proudest moment of my professional career, that we're able to show in the real world benefits from using real-time CGM that are actually far exceeded those in the randomized trial. So what we see in the real world is that women had improved pregnancy glucose levels before and during pregnancy, and that resulted in fewer just for gestational age babies, fewer preterm births, fewer neonatal intensive care unit admissions, and of course they're the costly things for payers. But actually the best results from the real world implementation is the fact that there was a 30% reduction in babies with severe congenital malformations or in baby deaths, either stillbirths or neonatal deaths. A 30% reduction in women on real-time CGM compared to those that are not. And of course you might just say, well, the women using CGM might be a bit more motivated or more advantaged, or there could be other differences. But the other fantastic result of the nationwide implementation is that only 3% of women last year were not using continuous glucose monitoring. So basically 97% of women were using real-time or intermittently scanned glucose monitoring, and that has led to a massive improvement in the most severe outcomes. Of course, we want all women to have nearer to normal, and we're totally proud of those successes. CGM has been totally transformational. But we do know from the concept trial that it still took many women until later in the second or early in the third trimester before they were able to get into that pregnancy-specific zone. So over the last 10, 15 years, we've been working with Roman Havorka and engineers and pregnant women to really develop the next stage technology after CGM. So CGM is the infrastructure, it's the roadmap, if you like, before you can develop any other technology. And then we've just had recently published the first randomized trial, the first large-scale randomized trial in pregnant women with type 1 diabetes using the hybrid closed loop or automated insulin delivery. And this is published in a very good journal, which is really fantastic and exciting. But actually, in terms of what I'm very passionate about, which is listening to women, The women's paper, the experiences, the lived experiences of pregnant women with type 1 diabetes is worth a read. And I honestly, I can't actually summarize it without crying. So all I can do is put it on the slide and say, please read it for yourself, of what difference it made, particularly for those women who'd had a previous pregnancy where they're finger sticking every half hour, they're up through the night, and now they have a system that will go some way, not a complete cure, but will go a long way to making the day-to-day management of type 1 diabetes a little bit smoother during pregnancy. So that's the successes with technology in type 1. CGM, and the work for that is largely done. The work to make sure now that the hybrid closed loop has the same uptake. Again, we will be aiming for 98, if not 100% uptake, is just going to hopefully, a little bit on hold until we hear from NICE, but hopefully that is something we can all start to work together. And let's see if we can build on those results from concept, but actually do even better. Let's see if for the first time we can start to get pregnancy outcomes for women with diabetes that approach those of the background maternity population. And my ambition is that we do the same as we've done for gestational diabetes. We might be aiming for even better as these technologies improve, but we will need your help, and we definitely need a strong nursing midwifery voice. I think, please start applying. We'll hang on to Partha for a bit longer, but hope that everyone in this room will seriously consider what they could contribute to leading in this space, because I think this is going to make a very big difference to patient care in the future. I'm going to shift focus a little bit and start to talk about what is the growing problem in pregnancy, which is the issue of early onset type 2. I am actually very cautious about my use of language, and anyone who has seen or read our paper will see that the Americans have changed our pregnant women into pregnant persons. I am not intentionally trying to be non-inclusive, but in the setting of pregnancy, birth, lactation and breastfeeding, it is crucially important that we use correct language. And for anyone who struggles, and I'm certainly still struggling and on this journey of how to not upset people from other genders or people who identify as women, I'd highly recommend this article, Effective Communication About Pregnancy, Birth, Lactation. And I'll show you a little bit, one concrete example of why this matters. So if we look at the population of those with early onset type 2 diabetes from the recent NDA and NPDA data, there's almost 10,000 people under the age of 25. Small number of children and adolescents, but the vast majority of those with early onset are actually in the 19 to 25-year-old age group. And if we call them just persons, we miss the fact that 2/3 of them are female. And then we are not targeting reproductive health care to their needs. They're not getting pre-pregnancy care. They're not getting 5 milligrams of folic acid. They're not getting access to safe, effective contraception. And if we look at kind of where these young people with type 2 diabetes are looked after, there are a very small number of them in pediatric clinics. There's only one of them per primary care, one in every GP practice. So, we can keep kind of saying, oh, the GPs should do a bit better. This is where all the women are. They're seeing them for care. Well, it's very, very difficult if you're just seeing one per practice. So we need to be mindful of the fact that whilst we're experiencing a tsunami of early onset type 2 diabetes in pregnancy, primary care colleagues, that is not their experience. And most of the people they look after with type 2, of course, are in their 50s, 60s, 70s and much older. But in our case, nationally, 54% of all pregnancies are now in women with type 2. And if we look at the larger in London, in Birmingham, in Manchester, in Liverpool, it's 70%. So this is a problem that is going to grow. And we should be doing better because actually, those of us who work in maternity, we know these women because up to half of them have attended our clinics a few years earlier with a pregnancy complicated by gestational diabetes. So if you do one thing after my talk, please start to change the conversation around gestational diabetes. Reassure those women they'll have good pregnancy outcomes, but start to treat gestational diabetes as a window into the metabolic health of that mum over the next 8 to 10 years. It's a unique opportunity to help her reduce her risks of going on to type 2. I'm going to show you now some data of why this is so important. These are data from the US, and it's a follow-up of 260 pregnancies in 141 women and girls with type 2 diabetes. And the first thing that's staggering there is just how many pregnancies there are in this small number of girls. The second staggering thing is the ethnic makeup, that the vast majority are non-Hispanic Black or Hispanic. They're aged only 20 years old. By the age of 20, they've already had type 2 diabetes for 7 years, and they have a BMI of 35 at the age of 20. Their entry HbA1c approaching pregnancy is 8.9%. A third of them already have renal impairment, and just over a third have hypertension, chronic hypertension. And I remind you, they're only 20 years old. These are the participants who are in a trial, so they're attending well-resourced clinics run by experts in the US. Only 16% reported any form of preconception counselling. That's not because they didn't give it. They were all given leaflets as part of taking part in the study. Only 16% remembered it. And only 15% reported using any method of contraception before their first pregnancy. And you can tell from those numbers that most of them went on and had a second pregnancy, and again without using any form of contraception, because nobody is thinking about it in that age group. When you look at how the women did through their pregnancies, 2/3 of them had a complication. The majority of that was to do with pregnancy-induced hypertension, so gestational hypertension or worsening of chronic hypertension, worsening of microalbuminuria, worsening of retinopathy. And around about a quarter had a pregnancy loss, which you might think, well, that's near to the expected numbers of miscarriages, but actually a number of those were late second trimesters. And you might think, okay, we are much better in the UK, and they're actually a bit rubbish in America, and they have this terrible healthcare system and lots of inequalities. And we are much more focused on doing everything we can to try and minimize healthcare inequalities. Well, yes and no. So when I started working with Jerry in Ipswich in 2002, 2003, so 20 years ago now, across the UK, there were 652 pregnancies in those with early onset type 2 diabetes. Last year, or for the last 4 years, the average number was 2,667. And there also is an increase of pregnancies in women with type 1 diabetes, so from 1,700 to 2,100. And of course, as well as that, there is an increase in pregnancies with gestational diabetes. And I started working in Norwich in 2015. And we now see more women per month than we did per year in 2015 with gestational diabetes. 12-fold more. And I can tell you, some of our midwives are here. We have no more staff. If anything, I would say we have fewer nurses, we have fewer dietitians. So we're seeing 12 times more women with gestational diabetes. We're seeing more women with pre-gestational type 1 diabetes, and many, many, many more women with early onset type 2 diabetes without additional workforce staff. And, there isn't, let's be realistic, regardless of what happens in this next election, there will not be more money. So we are going to have to figure out ways to work smarter to deliver the care that these women need. What we're also going to have to work very hard to do is to recognise that particularly for those women with type 2, early onset type 2 diabetes, when you look at any of these charts from the NPID data, so this is looking at socioeconomic from the least deprived to the most deprived. So for those with type 2, fewer than 5% of the pregnancies were occurred in women from the least deprived regions. For those in the most deprived, it was 42% of pregnancies, 7 times more pregnancies happening in women living in more deprived communities. And the vast majority of those women are coming from Black and minority ethnic groups. So it's not just that we're seeing more numbers of patients, it's that the actual complexity of the women we look after is so much more difficult than it has been at any time in the past, and that these women have so many other comorbidities on the medical side, like the women in the Today programme with hypertension and nephropathy, but they also have so much else going on in their lives that diabetes may not be the number one priority for them. And we know when we look particularly at those with type 2 diabetes, but including those with type 1, that only around about 50% of women with type 1 are getting access to folic acid before pregnancy, the higher dose for diabetes, 5 milligrams. Only 20% with early onset type 2. And it's pretty easy to say blame that on the GPs, but we have to remember that GP has only got one person in this age category. So we need to work out better systems for targeting the appropriate reproductive care to women with early onset type 2. And actually these women are being seen and they're seeking out healthcare professional advice because 2/3 of them are taking metformin. The majority are not reaching the target, the NICE target HbA1c of 48 or 6.5, but only 18% are taking insulin. So, we're not doing a good job of treating them to target coming into pregnancy. And we spend a lot of the pregnancy then on catch-up, just never quite getting them to the glycemia that they need to reduce complications. If we look at health inequalities, there's probably no aspect of diabetes care that I'm aware of that is more divisive than pre-pregnancy care, and that's the same in type 1 and type 2 diabetes. So it is the more advantaged, more educated women who are much more likely to be able to say to a GP or a diabetes nurse specialist, I'm thinking about having a baby. Women with lots of other stuff going on in their lives generally don't do that. And again, that is something we systematically need to improve. We've known this, and these data are, old and historic, but nonetheless unchanged, that even teeny tiny differences in maternal glucose, particularly in the first 4 to 6 weeks of gestation, are crucial for reducing the risk of serious adverse outcomes. So that's the serious birth defects, stillbirths, and neonatal deaths. And that's equally applicable for women with type 1 and those with early onset type 2 diabetes. So women in type 2 diabetes there in grey. And, ideally, the NICE target is currently set at 48 pre-pregnancy, but actually for someone with type 2, if they can get to 43, then that would be even better. They can do so safely. And I, like many of you, we've worked for years of trying to give information to women, give information to practices, give information to practice nurses, give information at retinal screening, give information at community pharmacists. I'm sure I've left out some of them. But we've done everything we can to kind of bombard this message. But you'd have to say with pretty limited success. And it's not rocket science, actually. The things you need to do to plan for a safe and healthy pregnancy, targeting glycemia, treating to target, stopping any potentially harmful medications, and getting women on folic acid. And how hard can that be? We should be able to do much better. My screen has gone blank, but that's okay. And together with colleagues across the east of England, we have when we've approached pre-pregnancy care in a much more systematic way and identified proactively which women in which GP practice are aged between 15 and 50 years old, and given them information, we've managed to get pre-pregnancy rates up to 50% for those with type 2. So with better systems and better systematic targeting of all people, rather than leaving it up to busy healthcare professionals to remember, I think we can do much better. And I just wanted to say that, we've known for many years that pre-pregnancy care improves outcomes in type 1 diabetes pregnancies. We haven't known whether or not it does in type 2 because we just haven't had enough women with type 2 who've attended. We do now know, and of course, again, it's no surprise that when maternal glucose matters in type 2, any improvement you can make in it is going to be at least as effective, and maybe even more so for those with type 2 than type 1. These are the data now from just from the recently published State of the Nation report. And these challenge a little bit of what we've been doing conventionally for many years, in that they tell us that the treatment target, so the HbA1c of 48 before pregnancy, is probably not low enough or tight enough or good enough for most women to have good outcomes in terms of the obstetric complications. So for preterm births, for large birth weight, for neonatal intensive care unit admissions, we really need to be targeting an A1C of less than 43. And to do that by 24 weeks basically means, because your HbA1c is reflecting glucose over the previous 6 to 8 weeks, means that kind of from the end of the first trimester, we want women to be treated to as near to that newer, tighter target as possible. And this is much more safely achievable now than it was in the past, particularly in type 1, where we have widespread access to CGM. And hopefully, hybrid closed loop will make that even more achievable in the future. This is one of the most upsetting slides and one of the really concerning things that has come out in the State of the Nation report yesterday. And this is looking at baby deaths, so stillbirths or perinatal deaths. And it's looking at them in categories or bundles of HbA1c. And this is the HbA1c after 24 weeks. In women with A1Cs of up to 43, up to 52, and so on. And if you look closely for those with type 2 diabetes who are in the grey categories, at every single glucose bucket, women with type 2 have a higher risk of having a stillbirth or a neonatal death than women with type 1. So this suggests that we've always been very aware that those with type 1, of the importance of maternal glucose in type 1 diabetes. But we've, I think, maybe underplayed the importance of maternal glucose in type 2 diabetes. And these data suggest that glucose might be even more important in type 2 diabetes than it is in type 1. And that is not to say it's not important in type 1. What I'm saying is it is even more important to more aggressively target glucose in type 2 pregnancies. So that is why the Saving Babies' Lives Care Bundle has really asked teams to, if you see a woman with an A1C of greater than 48, you need an MDT meeting, you need an action plan, you need to do something different, because this is a pregnancy with a potentially preventable baby death. If you have women who are almost to the target, so 44 to 48, still have a think, could anything else be done to support her to get that target a bit tighter, again, to reduce the risk of a death? The other thing I just want to mention very briefly, and this came up you saw in the earlier program of the younger girls and women with pregnancies, that many of them after a complicated pregnancy didn't do what we might think they would do, is go and get themselves on contraception. Actually, what happened was the factors that led to them being unable to plan their first pregnancy were still there in the next pregnancy, and they still didn't have contraception. And I love this description. This is from colleagues in Northumbria of, what happens, the provision of care in pregnancies after a stillbirth or a neonatal death. And it is literally everything from marvellous to mediocre, as this article suggests. So I think we're very good at the immediate, practical, emotional support for those women. But what we fail to recognise is that the average time from a stillbirth or a neonatal death to the next pregnancy is under 1 year. And that the vast majority, we feel sensitive, we don't want to talk to them about contraception after a loss. But we're really doing these women an injustice if we don't prioritise postnatal contraception and find a way, however difficult, to make that part of the normal care for someone with a loss. And just finally, on my wrapping up slides, I want to just mention in the aftermath of the Ockenden report, where so many women, particularly those with bad outcomes with baby deaths, felt frightened and not listened to. And when we speak to women with early onset type 2, there's this massive stigma associated with the condition, some of which is self-perceived, some of which is external. And when we ask those women what they want, is they want more focus on the positivity. They want this message loud and clear that small differences that they can make to the maternal glucose will really improve the baby's health. And like this woman said, more focus on the positivity of managing the glucose levels and the results of that in her pregnancy and birth. And this, they don't want the rocket science or all the data and numbers I've thrown at you. They just want to know what can they do to be able to deliver naturally? How can they manage the diabetes without compromising their mental health? And this is just a mention, if you've not already heard about it, the Today programme, which is funded by NHS England, which is a proactive identification of everyone with early onset type 2 diabetes, so aged between 18 and 39, and making sure that their care is targeted, that they're not treated in the same bucket as older age people with type 2 diabetes, but they get checks that are unique to their more severe form of diabetes. And then this is probably what I think the single most important thing we need to do in our gestational diabetes clinics. We need to make sure that these women are coded on the maternity services data set so we can examine their pregnancy outcomes. But even more important than that, we need to tell every single woman who's had gestational diabetes that she is eligible for the National Diabetes Prevention Programme, and that this programme works just as well in younger age women than it does in the older age participants who've had fantastic results. And I don't care if the woman wants to do Slimming World, Weight Watchers, the NDPP, but that she should be able to have a discussion about doing one of those things. And we know that most of these women are pretty good at having their postnatal check. The annual HbA1c falls off the radar, and the uptake of women with GDM in the diabetes prevention programme is so poor, and that is not because the women do not want to prevent type 2 diabetes. It's because our systems in maternity don't speak to our systems in diabetes, don't speak to our systems in primary care. So we need to work harder to get these systems talking to each other. So what I will leave you with is some of the fantastic success that we've achieved with the rollout of technology, both from CGM and hopefully in the future from hybrid closed loop. Those with early onset type 2 need much more targeted care and support, better access to effective contraception and pre-pregnancy care programs. We all need to be focused on much tighter glucose targets, both in type 1 and type 2 diabetes. We need to know much more about how to support those with type 2 to get tighter glucose. Will CGM be as effective in type 2 as it is in type 1? Should we just say, yes, it's going to be and roll it out? Or do women with type 2 deserve the same high-quality evidence as those with type 1, which is certainly my personal view? And then there's lots of good stuff happening across the NHS. There's Saving Babies' Lives, there's the Today programme, there's the National GDM audit, there's the Diabetes Prevention and Remission. And I'm very proud that I was able to put this into my slides. This is high tech for me, but if you do just one thing, start collecting your GDM data so you can know how well your service is doing, what your numbers are, and how we can prevent these women, many more of them, developing type 2. So thank you very much for inviting me. Thank you for listening. I'm happy to take questions, but I way prefer them from someone's face I can see than typed, so please be brave.